It's my pleasure to introduce Noushin Saadullah Khani. She's doing an interdisciplinary PhD, including health economics. So co-supervisors who are health economists are Barbara Barrett and Lily Huaji from King's. Over to you, Noushin.
Thank you, Alvaro. So hi, everyone. I'm going to be sharing with you my PhD project, which is essentially evaluating whether genomics can enhance care and quality of life in psychosis. So I'll just begin by giving some background into the project. So over the past few years, we've been seeing this steady increase in the prescription of antipsychotic medication from 8 to 12 million prescriptions from 2008 to 2018. And we do know that antipsychotics can significantly improve the quality of life of patients, but we definitely see a variation in the response and the tolerability of medications among patients. So while some patients improve quite a lot on antipsychotic, others might show no response or they experience adverse drug reactions on that same antipsychotics. In terms of these adverse reactions, we know that antipsychotics are associated with extrapyramidal symptoms, and these include tremors, involuntary muscle contractions, and involuntary facial movements. Some of these can also be long-lasting symptoms. We also have some antipsychotics which are associated with a high, so this includes weight gain, high cholesterol, and high blood pressure. And some patients may also be resistant to treatment altogether. So approximately 30% of patients don't respond to antipsychotic treatment. At the moment, treatment for schizophrenia involves this trial and error approach in which patients undergo several cycles of antipsychotic drug therapy until an improvement is eventually reached. One potential alternative to this approach is this genetics-guided approach. So after you take a drug, your body has to break it down and get it to the area that you want it to. And there are many factors that affect this process and therefore influence the way that you respond to a drug. So this can include your age, your sex, the environment, and also, of course, genetics. Now, everyone's genetic information is different, and we can use genetics to tailor treatment to each individual to take into account some of these differences in drug response. This is known as a pharmacogenetics guided approach. So I conducted a systematic review as part of my PhD to investigate whether genetic testing in adults who are taking antipsychotic medication to optimize their treatment improves clinical and economic outcomes. So in a nutshell, a systematic review is a thorough and detailed review of the existing literature on a particular topic or research question. We looked at several databases and also searched for papers by hand. Our inclusion criteria was quite broad due to the limited data in the field, so we didn't apply very many restrictions in terms of patients' age, their diagnosis. We also didn't apply any restrictions by study design, country, healthcare setting, or monetary currency. So after we screened papers based off of this eligibility criteria, this left us with a total of 13 studies in the systematic review. And this review found that the studies included were very different from one another. So for example, there were many different study designs. This included clinical trials, observational studies, and also economic models. There were also many different outcomes reported. So for example, we had adverse reactions, symptom severity, hospitalization information, medication information, cost information, and many other outcomes as well. So it was quite difficult trying to interpret the results from all of this data. So to facilitate this interpretation, we visualize the results for each outcome using the graph that you see on the screen. So the graph on the left represents the results for the clinical outcomes, and the graph on the right represents the results for the economic outcomes. On the x-axis, we plotted the p-values as a measure of the strength of the evidence, and we have a solid line in the middle of the graph, which represents a p-value of 1, so no difference between the treatment groups. And we have a dashed line, which represents the significance threshold of 0.05. This represents either improvements in the genetics guided group on the right, or an improvement in the treatment as usual group on the left. And then on the y-axis, we have several different outcomes of interest. And as you can see, most of the data points are either in the middle of the graph or towards the right side of the graph. What this means is that the current evidence base is either in favor of this genetics guided prescribing, or they show no difference between the genetics guided treatment and the treatment as usual. And of course, it's worth mentioning that there were no studies that favored treatment as usual. However, there were many limitations to this evidence base. For example, small sample sizes. There was quite limited diversity in the sample. There was also a lack of blinding of the participants, the clinicians, so on and so forth. Ultimately, our conclusion was that we needed further studies with sufficient sample sizes in patients who were taking antipsychotics. So this review provided kind of justification for doing my own analyses. So in this study, I did a cost effectiveness analysis of genetic testing to optimize treatment for schizophrenia using a type of health economic model called a decision analytic model. Now, economic evaluations are usually conducted alongside randomized control trials to provide researchers with individual patient data to estimate cost effectiveness. However, these trials have several limitations. So they're usually conducted over a short period of time. And secondly, the data from one single trial alone might disregard information from other trials, as well as meta-analyses and observational studies. So the two main reasons for choosing this modeling approach was to allow for extrapolation over a patient's lifetime. This would allow me to capture differences in outcomes. And secondly, to allow for synthesis of information from multiple sources, rather than just relying on one single trial alone. There was a similar cost effectiveness analysis that was previously conducted in a UK setting, and their study concluded that the pharmacogenetic intervention was indeed cost effective. However, their study was conducted in 2013 when there was very little data on clinical utility of this genetic testing. So an updated study based on recent data is required. So I created a decision model, which is comprised of a decision tree with a Markov model. So I'll first discuss the decision tree, which is basically just a map of possible outcomes from a series of choices. So within this decision tree, the genetic testing strategy was compared to treatment as usual. After undergoing genetic testing, patients can either have a genetic variant that affects their rate of drug metabolism, or they might not have any genetic variants. And of course, I wanted to capture testing inaccuracy. So there was a small minority of patients who were incorrectly detected as having no genetic variants, and these patients were false negatives. And we had an even smaller minority who were incorrectly detected as having genetic variants, and they were false positives. From this decision tree, the patient then enters a Markov model, and a Markov model represents different disease states to represent all the different, all possible outcomes of a disease or a condition. And within this Markov model that I created, the patient initiates a first-line conventional antipsychotic. If the patient doesn't respond to that first-line antipsychotic, they are then switched to a second-line conventional antipsychotic. If they don't respond adequately, they are then switched to clozapine. After initiating the conventional antipsychotic or clozapine, the patient can enter the health states stable or relapse. So the analysis showed that the genetic testing was cost effective against treatment as usual and incurred lower cost and more QALYs. So the results from the analysis showed that the genetic testing could potentially save 37,000 over a single patient's entire lifetime and could produce 0.4 additional QALYs. And just to clarify, QALYs refers to quality adjusted life years, And this essentially takes into account how a treatment affects a patient's quantity of life, so how long you live for, as well as their quality of life. So the QALY combines both of these factors into a single quantitative figure to measure the health benefits of a treatment. This meant that the genetic testing strategy was the dominant option, so this means it's less costly and also more effective than treatment as usual. So of course, the decision modeling relies very heavily on validity of input data. So we did sensitivity analysis to see if changes in the input data would affect the results. We did one-way sensitivity analysis where we test the validity of each individual parameter by seeing how the costs and QALYs accrued over the patient's lifetime changed after testing the upper and lower limits of each parameter. And we found that the pharmacogenetic testing was still the dominant option after testing all of these parameters. So it was robust. We also did probabilistic sensitivity analysis, which tests joint uncertainty of multiple parameters simultaneously, which showed that there was a 64% likelihood that this strategy was the cost-effective option. And my conclusion from these results was that pharmacogenetics could be a cost-effective option, and this has been shown in previous literature, as suggested by my systematic review. However, the results from the probabilistic sensitivity analysis does suggest that this finding should be interpreted with caution, as the probability of cost effectiveness wasn't as high as we hoped. So to conclude, we understand that antipsychotic medications on the market does currently work, but that they could be optimized. So we're looking to develop this genetic intervention to guide the prescribing and dosing of antipsychotic medication. However, genetics isn't the be-all and end-all, but it's a tool to help clinicians understand more about the patients that they are prescribing for. I just want to say a very quick thank you to my supervisors. To my supervisors for supporting me in my PhD, and of course to Mental Health Research UK for making this PhD possible. Happy to take any questions if you have time.